Well, my interest in this got started because I'm a spinal cord injury rehabilitation physician, but I had patients, and one in particular who I can still see before my eye, lying in bed, life changed forever, horrendous pressure sore that developed and acquired and progressed while prolonged hospitalization. And this person, I've never talked to him about it, but he's kind of the motivation why I keep going to these meetings and keep pushing for change and don't let it drop. I just feel like, you know, I've been so blessed that I gotta push through for these people who the system wants to push out. There's not enough of them to meaningfully vote. No doctors, by and large, are compassionate toward them, but don't know what to do because they can't cure them. So that's why I keep doing this. Well, it's been wonderful. I got the opportunity to work with the clinic as the physician leader on a group that were to address what are called never events. That means they should not happen to a person when they're in the hospital, which I think is poorly named. But the group that I'm with has the highest incidence. It's called pressure sores, and every hospital, every health system has them. Our patients have them, and our goal is to manage them so that the patients have the fewest and they get the best care possible. And so it's been a real educational and effective process. When we began, patients were receiving good care, but we would get reported, and this is a report of any new pressure sore or pressure sore that gets worse per grade. The pressure sores are graded. And we would get reports of those. And when we started, we were getting many of them. I think our highest year was 2010, 2011, when we were in the 40s of reportable pressure sores. We instituted really an educational program for the nurses that provide the great care that has just made a tremendous difference. Our number of pressure sores reported is cut to less than half. I checked, we're at 14, I think, for this year and 20 for last year. And we're literally checking ourselves because so many of the times we look at all the criteria. Did the person have the proper nursing care? Did we document that we tried to provide the best care possible? Did we get them the best equipment, be it a bed, be it a wheelchair, be it whatever? And are we providing the topical wound care itself? And the care has always been good, but our documentation now of the fact that in these 20 who still get pressure sores, that we did do our due diligence. They did have the right equipment. They did get turned. They did get inspected. They did get their wound care, but their organ, which we deal with, the skin, is just failing. And so it's been rewarding to see how the whole nursing, both hospitals, Methodist and St. Mary's, how they mobilize together through their structure. And there's been a lot of education, a lot of work, and it's really cut down on the number of pressure sores. Well, we came up with a team process. I'm the physician representative. There are nurse leadership representatives, nurse educator representatives, but the process we came up with is that when someone develops a progression or a new pressure sore on our watch, if you will, we institute an educational program that involves both the care of the wound, proper bed, proper cushioning, proper turning, and the documentation of the fact that those items have been addressed. The wound care items, the equipment, the care, the inspection, the education, and it's really just been wonderful to see how much each nursing unit really cares. Well, the care is more than simply do they have the right bandage or ointment on their wound. It's do they have the right equipment? Do they have the right inspection schedule? Are they turning regularly? Are they doing the cares appropriately depending on which of the different wound dressings we choose? So it's kind of expanded from, most people think you just put the proper product on a wound and it will heal, but we know that it really takes everything. You got to have pressure relief, you got to have good nutrition, you have to have proper equipment, and then the nurses have really improved on documenting that we are doing those things. And that has been really rewarding to see, to the point where it's a little bit disturbing that so many times we see a pressure wound that's developed or progressed, and we see, gosh, we've got the right training, we've got the right equipment, we've got the right wound dressing, we've got the right patient education, but the patients that we see tend to be so ill that we still have a small percentage of ulcers that develop and progress. We are there to a degree in that there are some quality projects that have been done that we've shown improvement in quality through looking at our documentation. There have been some research projects by our clinical nurse specialists with interest in wound care looking at this whole process. So yes, it's being studied, but the emphasis right now is more patient care than research. Really, the first year was a learning year where we were all learning how, to our surprise, how frequent it was that people had wounds that progressed or developed on our watch, and that was bothersome to us. And it was just amazing to see over the next year how each nursing unit that would go through this response, because we come in and hang a great big, what's called a causal tree document that covers whole walls of a room. And each nurse who cared for that patient can come in and can write on there anything that they think helped, or not helped, but caused or worsened the wound or was unique in this patient's situation. So we end up with this large document with input from all the nurses as to what we think we could have done better. And then we summarize that, do an education document, goes back to that nursing floor. But the nursing floors, they all talk to each other. So this just kind of snowballed. And again, as a physician, I was just really impressed by the nursing leadership and the bedside nurse taking this very seriously. And so we've cut those numbers by at least half. And the ones we see now, I'm pleased to report, usually we look at, did they get the right training? Did they get the right equipment? Did they get the right education? Do they use the right product? Are we on the right bed? And we're going, yes, 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 yes. And so we still lament and grieve that the patient had the pressure sore, but we're pleased with the nursing care that people got and with the documentation that we can defend and teach ourselves that we've done a good job. But it can be something as simple as somebody who's in a life and death struggle for breathing, and the mask that we use on their face, because of the boniness of their particular nose or the fit of the mask, they get a pressure sore underneath there. Now this generally, once the respiratory problem goes away, is resolved, but we've had real good support from the ENT community, the ENT nurses, the floors that this happened on, that we look at and say, you know, how can we prevent that from ever happening again? Again, we look at those same things. Are we using the right equipment? Are we giving the right training? Are we doing the right inspection? And those kind of things have been surprising to me as a rehabilitation doctor, thinking that most of these pressure sores would be in spinal cord injured patients, but it turns out that the severely medically ill are at risk as well. One of the things I really liked about this is I got the genuine sense from Mayo leadership that they were interested in this to help our patients not to follow the rules. And sometimes you can get disillusioned and think that the motivation is to be in compliance. But I quickly picked up that no, none of us, from the physician leadership to the nursing leadership, were comfortable with the fact that we could be doing less than our best for these patients with these problems. And so that as somebody who's been here 25 years, you know, I was pleasantly surprised to see. Well, I think the next steps for us are to continue to monitor, to continue to educate, and address the trends that appear. Right now, what I see unscientifically is that the critical illness nature. One of the things that's interesting as Mayo goes forward with standardizing our care is we've run into problems where two different standardized care models conflict, and we have to make a decision. For instance, the ventilator associated pneumonia program, which is called the VAP program, capital VAP, they have mandatory within the program, the nurses feel stressed because they're supposed to be sitting up at least 30 degrees in the bed. For the pressure sore relief program, we know that if one of the worst positions a person can be in to get a sacral pressure sore is to be sitting in bed at greater than 30 degrees. So we are working on how do we provide best care for the patients, both keeping them alive from a pulmonary standpoint and protecting their skin. So I think we're going to continue to run into more collisions of programs like that. My aha moment as to what's really missing here was, I'm thankful to say, not the care, but the documentation. That we would have people whose wounds would develop or progress, and we would not have the documentation. That well-meaning, excellent, super quality citizen nurses would be telling you, well, I know I did this multiple times during my shift, but it wasn't a high priority, or it wasn't easy, or it wasn't available to document. So then now we've got still that ongoing good care, which we usually had in the past, obviously not always. And now we've got much more heightened awareness of the need and the ability to document. The information technology people have helped us. We've developed these automatic polls that if the nurse notices a pressure sore, the doctor can't sign his note until he pulls that in or comments about that. So the system is helping us to recognize that, oh, there's another comorbid or also existing impairment or problem that this person has. So we're, as an institution, we're changing, we're learning so that we provide better care in the future.